Good evening, everyone, and a very warm welcome to our esteemed faculty and delegates attending this session. I'm Dr. Sana, representing AstraZeneca Medical Affairs. In this scientific engagement that we have lined up for an hour, we are trying to focus on EGFR-mutated non-small cell lung cancer landscape. We have in the session some of the renowned experts in the field of oncology. And with this, I invite our program director, Dr. Purvish Parikh, medical oncologist, Asian Institute of Oncology, former head of Department of Medical Oncology, Tata Memorial Hospital, Mumbai, to give the opening remarks. Over to you, sir.
Thank you very much, Dr. Sana. I hope I am audible.
Yes, sir, you're audible.
Excellent, excellent. So this is a wonderful opportunity for me, and I'm delighted to be part of this special program for AstraZeneca. We have a very important keynote speaker, and if I can have the slide on. Right. So our international speaker is Dr. Tim Clay. His topic is evolving paradigms of EGFR mutated non-small cell lung cancer treatment in the future. EGFR is well known, it has been established, and we know that how much benefit we are giving to our patients, but we have first line, second line, and third line treatments for this particular mutation. And it is our honor to have Dr. Tim Clay as our international speaker. Dr. Tim is adjunct associate professor at Edith Cowan University and is a medical oncologist at St. George of God Healthcare, Australia. So with these introductory remarks, I don't want to stand between you and our international speaker. So over to Dr. Tim, please.
So you will have to unmute yourself.
Thank you very much, Dr. Parikh, and thank you to Dr. Sana and the team at AstraZeneca for inviting me to talk to you this evening. I'll just get my slides up. I had the pleasure of visiting India last 3 years ago to talk about durvalumab, and now returning to talk about the management of EGFR mutant lung cancer and how our treatment paradigms have changed over time. By way of background, the journal Thoracic Oncology publishes a series regarding lung cancer in various countries, and this article on the state of lung cancer in India was published in 2021. And you can see that the majority of people in your country are dependent on the public health sector, and although there's a large amount of expenditure, there is probably much room for improvement, like there is in every country around the world. Tobacco use remains relatively common at a little over a quarter of the population, despite efforts from oncologists, physicians, and groups to try and bring this number down. Interestingly, I discovered that the amount of tobacco crop grown worldwide takes up around the same surface area as the country of Switzerland. Lung cancer remains the fourth most common cancer in India, affecting around 6% of people, and the incidence across your country on a yearly basis is around 100,000 individuals, of whom EGFR mutant lung cancer occurs in approximately 30% of patients. So we've been, with the history of EGFR mutant lung cancer, it's been like climbing a staircase in terms of approval over time. And we started with a median survival with chemotherapy in unselected non-small cell lung cancer for around 12 months, but we know that EGFR mutant lung patients often lack some of the comorbidities of tobacco smokers and may actually do a bit better than this with chemotherapy. The first generation inhibitors moved the median survival time to just shy of 2 years, and this was the data for gefitinib from the IPASS cohort, replicated across a number of studies of first-line EGFR inhibitors. Although with exposure to EGFR inhibition in sequential lines of treatment, no actual survival benefit was realized over gefitinib in this study and in many of the other studies. The second generation inhibitors like afatinib and dacomitinib improved the median survival to around 34 months when compared to first generation inhibitors. But you see from the Archer study of dacomitinib that the median survival for the patients who were randomized to first generation inhibitors was also improving up to 27 months. And finally, we come to the most impressive data presented to date from the FLORA study in stage 4 disease, pushing the median survival for someone who's able to access first-line osimertinib now over 3 years, compared to the control arm at 32 months. I still remember commencing my training in 2010 and coming across these medications for the first time. And just in the last decade, we've gone from first to second and third generation inhibitors. And so the question for tonight is what lies beyond third generation EGFR inhibition? So one of the questions that I pose is, why has osimertinib grabbed centre stage in our attention? And the major reasons are the survival outcomes that I've already shown, the tolerability of the drug. So when EGFR mutations and EGFR first generation inhibitors were developed, the presence of EGFR mutation was not known, and this was only discovered through translational research, whereas the third generation inhibitors have been rationally designed to try and minimise wild type blockade and improve their tolerability. And thirdly, the new generation inhibitors that are coming on are also penetrating the CNS and giving longer periods of disease control in this space. The data from FLORA was first presented in the public domain at ESMO Madrid in 2017, around 4.5 years now. And as is well known to many members of this audience, this was a study that included patients with exon 19 deletions or L858R point mutations, so the most two common mutations that we see in EGFR, and no prior systemic therapy for advanced disease. And importantly, in this study, stable CNS metastases were allowed. The study was powered to a primary endpoint of progression-free survival, with secondary endpoints as usual in the study, including response rate, survival, and tolerability. And in the study, patients were randomized in a 1-to-1 fashion to osimertinib or standard of care gefitinib or olaparib. Importantly, in the standard of care arm, crossover to open label osimertinib was allowed for patients who developed T790M as their resistance mechanism, as the AURA3 data had already become available at the time of reporting of this study. What you can see in the first primary presentation of the data is a striking improvement in progression-free survival with osimertinib, with the median reaching just shy of 19 months as opposed to the standard of care at 10.2 months. The hazard ratio was 0.46 and was highly statistically significant, and this rapidly placed osimertinib as the standard of care in EGFR mutant lung cancer and advanced disease. We see across the forest plots for progression-free survival, all subgroups benefited. There wasn't anyone who did better or worse with osimertinib. And then 2 years later, again at ESMO, the overall survival data, the final overall survival analysis was presented for this study. And what this showed was that over time, there was a just short of 0.8 hazard ratio, so a 20% reduction in the risk of death at any time point, again, statistically significant. And at a 3-year landmark, there was a 10% improvement in the likelihood of being alive from 44% to 54%. In the forest plots, all of the subgroups were either to the left of unity or sitting on unity. And there was some conjecture made about whether or not the race of a patient was important. And I think one of the things that osimertinib gives over a first generation inhibitor is protection from CNS metastases. And you'll see later on in some other studies in Asian-only populations that benefit for third-generation inhibitors still holds. So it's not a specific issue as regards to patient race. And the benefit perhaps wasn't quite as great in patients with L858R mutation, but we know that there's a progression-free survival advantage. And this study was not powered to detect differences via the mutation type that was entered into the study. The safety summary of the study, you can see here, there was a higher rate of grade 3 adverse events in patients who received a first generation inhibitor as opposed to a third generation inhibitor at 29% versus 18%. And while the numbers look numerically similar, there are some differences in this population. So particularly as it relates to skin toxicity, the total number, sorry, the rate of grade 3 skin toxicity was 7% for a first generation inhibitor versus 1% for a third generation inhibitor. When you drill down into that more closely, the grade 1 and 2 events, there was actually a much higher rate of grade 2 toxicity with the first generation inhibitor at 31% as compared to only 9% with grade 2. And many of you will be familiar with the typical appearance, the acneiform rash that you can see with EGFR inhibition. And for a patient who is going to be on these medications for a long time, that can be particularly disfiguring and distressing, and may flag to people that they know that they have a medical condition, they're on treatment when it otherwise might not be obvious. The other difference was a lower rate of liver dysfunction with Olimertinib, although in my experience it hasn't really been a major problem I've had to deal with the first generation inhibitors, but it is a point of difference in this study. I would also say in my clinical experience, although some of the numbers look similar, I find Olimertinib is an easier drug to give than the first and the second generation inhibitors. And I don't routinely give prophylactic doxycycline or minocycline when I'm giving Olimertinib, whereas I do when I'm giving a first generation inhibitor. Because of the success and the clear advantage of Olimertinib in the FLORA study of metastatic disease, AstraZeneca has brought this molecule forward into 2 other studies in earlier disease that are already, one of which is already read out, which is with the Adora phase 3 study. In this study, patients who had completely resected stage 1B through to 3A non-small cell lung cancer with one of the 2 common groups of EGFR mutation were randomized either to receive Olimertinib or a matched placebo. And this study allowed enrollment regardless of the receipt of chemotherapy. The planned duration of treatment was 3 years of continuous Olimertinib until recurrence, completion of treatment or discontinuation, and patients were routinely followed over this time. What will follow next is perhaps one of the most impressive progression-free survival curves for many years in this study. You can see that the rate of recurrence for patients treated with placebo was very high, consistent with the stage of lung cancer that they had, with only 28% of patients remaining free of progression at 3 years, although the numbers are getting small by then, as compared to 80% receiving Olimertinib. And I think all of us who are watching this data being presented were very impressed by how effective Olimertinib was in this situation. However, this study was not without controversy. Like many people in India, Australia is a country that loves its cricket, and Vinu Mankad named the method of dismissal, the Mankad, a very controversial way to get someone out in cricket. And similarly, Adora has not been without its controversy. And there are a number of reasons why. Firstly, the prior adjuvant or neoadjuvant studies of first-generation TKIs have shown a clear disease-free survival advantage when compared to chemotherapy. But as yet, none of those studies have shown an overall survival advantage. And the question will be, is this going to be similar to the first generation inhibitors in stage 4 disease, or is this a real effect? The second reason why clinicians have some hesitancy is that the overall survival data from this study is not yet mature. And so we don't know if the early receipt of Olimertinib is going to lead to people living or surviving their cancer more readily. Disease-free survival is accepted as a surrogate endpoint by the FDA in the US and a number of other groups for survival outcomes, but as pointed before, EGFR inhibitors haven't shown a survival advantage in this setting. And what I think we're all waiting to see is, once patients in the experimental arm complete their 3 years of therapy, are they going to remain free of disease, or are they going to relapse? if patients relapse, then the question will be, should they actually remain on Olimertinib for a longer period of time or lifelong? If they remain free of disease, then the question that we'll want to ask is do we really need to give people 3 years, or can we get away from less? And I think as clinicians treating early stage disease, the goal that we have to have is higher rates of cure of cancer. Finally, there's some concern that given Olimertinib is a new, highly effective and well-tolerated therapy, there may be a desire for people to avoid chemotherapy given its known toxicities and effects on quality of life. But chemotherapy in this situation has got a proven overall survival advantage, albeit small. And there may be a risk that people will abandon chemotherapy too early in the pursuit of targeted therapy. We know that almost half of the patients in the control arm, or in fact in both arms of Adora, did not receive chemotherapy, and we can see that the relapse rate in the placebo arm was quite high. And so the question is whether or not those relapses were driven by patients who chose not to receive chemotherapy, or if it was something to do with the study itself. The two studies that are in progress and that are randomizing, that are going to provide further information on the role of Olimertinib are firstly in the setting of stage 3 disease. So the LAURA study is looking at patients who have stage 3 disease who are treated with standard chemoradiotherapy with curative intent and remain free of disease progression. And it is randomizing patients in a 2-to-1 fashion to either receive Olimertinib or placebo. The difference between LAURA in stage 3 and Adora in resected disease is that Olimertinib in this study will continue until progression, as opposed to stopping at a predefined time point. The control arm in this study is placebo, and one question that we tackle with the EGFR population is, given the data from the Pacific study of immunotherapy, whether or not we should in fact be giving patients durvalumab. And in the Pacific study, there wasn't an advantage realized in the EGFR cohort for durvalumab in terms of recurrence or overall survival, but one must remember that that study was not designed or not powered for the EGFR cohort. A concern with giving durvalumab is that should a patient progress and need to change to Olimertinib, there is some data showing that TKIs, not just Olimertinib, but TKIs in lung cancer in general and immunotherapeutic agents carry a very high risk of toxicity. So again, it's a rationale for perhaps not giving durvalumab in EGFR mutant patients. And certainly if LAURA can show the same sort of freedom from recurrence or progression that we saw in Adora, that will very quickly become adopted as the standard of care for patients with stage 3 EGFR mutant disease. The other very interesting study that is recruiting is the Neodora study. I'm quite disappointed, as I'd proposed a study of a similar design called Octane, and I thought my name was much better than Neodora, but be that as it may, the convention of ending all Olimertinib studies in AURA continues. And this study is going to help answer some of the questions that have been raised by the Adora study. So this study is patients with stage 2 to 3B disease, again with one of the common 2 mutations, randomizing to the control arm of chemotherapy plus placebo, which would be an accepted standard of care, versus chemotherapy plus Olimertinib versus Olimertinib. And the initial endpoints and the early readout that we will get from this study is the major pathological response. A major pathological response in this setting is defined as less than 10% residual cancer in the resection specimen and the rate of pathological complete response for each of these arms. And then patients will go on to additional adjuvant therapy as per the choice of the investigator, with follow-up event-free and overall survival. and it will help us pick which of these strategies is going to be potentially the most successful, and also may provide us some data about how we might select adjuvant therapies based on the response to neoadjuvant therapy in this population. Osimertinib so far has been the great success story for third-generation EGFR inhibition, but there have been a number of other compounds that have been developed and have fallen by the wayside. And you can see that the 4 compounds at the top have been struck out for various reasons. Of these, the one that got the furthest down the track was an agent called Olimertinib, which was being developed at around the same time to target T790M. And the problem that this agent had was that it hit another receptor, which has fallen out of my mind. Insulin-like growth factor receptor, as well as EGFR, and it caused quite high rates of treatment-induced diabetes, and also had a less than favourable response rate compared to osimertinib, and it fell away. A number of the agents, so Nezertinib, Lazertinib, and Olimertinib have moved forward with studies, and 2 other agents have recently been presented and are in trial, so Bofinertinib and Resivertinib. So the number of competitors that are coming to challenge osimertinib's spot continues to rise, and some of the phase 3 studies for these agents have already read out. So last year at ASCO, an all-China study of Olimertinib, another third-generation inhibitor, was presented, and in this study, the experimental drug was compared against the standard of care first-generation inhibitor of gefitinib. Brain metastases were allowed, and the rate of brain metastases in this study was a bit higher than was seen in FLORA, so almost a quarter of the patients had CNS disease. Essentially, the study design was pretty much a carbon copy of FLORA, and importantly, crossover was allowed for patients receiving a first-generation inhibitor and developing T790M mutation as their mechanism of resistance. Again, the survival curves from this study look very, not dissimilar to that of FLORA, with Olimertinib realising a 19-month median progression-free survival as compared to gefitinib at around 10 months, with a hazard ratio of 0.38. Similarly, the overall survival data from this study, which has recruited a bit later, is not yet mature, but the hazard ratio is looking not dissimilar to that seen in FLORA at 0.82. In terms of significant side effects from the drug, you can see that Olimertinib had less both rash and diarrhea of any grade compared to gefitinib, and so on. In that regard, is likely to be a better tolerated agent in terms of side effects that can impact on patient quality of life. And recently presented in the last few weeks at the European Lung Cancer Conference were 2 new agents also emerging from China. Furmonertinib was presented as a first-line phase 3 study, again against gefitinib, again with a similar study design to FLORA and the Olimertinib study, and showing very similar median progression-free survivals between Furmonertinib and gefitinib. A second study with a third-generation inhibitor called Outrun was presented, which included patients with second-line T790M positive disease following a first-generation inhibitor, and again showing quite a high response rate at 60% and a median progression-free survival of just over a year, although this agent had fairly significant diarrhea. The rise of targeted therapy groups around the world in terms of patient advocacy has been quite rapid, in part because oncogene-driven disease tends to disproportionately affect never smokers. And the EGFR resistors is a group that commenced in America but has members around the world of patients who are living with EGFR mutant lung cancer. And the objectives of the group in terms of what patients want are to improve outcomes, to manage disease and to do this by continuing research. And I think it's very important as clinicians that we think about when we're developing therapies for our patients, what things are important in day-to-day life. So I would contend that an optimal therapy is one that is most convenient for the patient. And generally, we would think that an oral therapy that a patient can take at home would be more convenient than something that requires infusions either in the clinic or at their home. The patients generally want the longest possible survival they can, but they want it with the best quality of life. So they don't necessarily want to sacrifice longevity for significant side effects. And so this is something that all of our patients weigh up when we make offers to them. I'm going to move on to presenting some of the new studies that are either currently in recruitment or have finished recruitment and we're waiting for a readout. So the first study is a study called Mariposa, and Mariposa is comparing Olimertinib in arm B, which is the current standard of care, to the third generation inhibitor Lazertinib. And these two arms are double blinded, so patients won't know which EGFR inhibitor they're receiving. The second experimental arm, arm A, combines amivantamab with Lazertinib. Amivantamab is a bispecific antibody that engages both EGFR and c-Met, and c-Met, as I'll show you later, is a potential resistance mechanism to EGFR inhibition. As many of you may know, this agent already has accelerated approval in the United States for its activity in exon 20 EGFR mutations that we're not covering in detail tonight. And so really the interesting question for me is whether arm A can better arm B or arm C in terms of survival. The downside of arm A is that it requires the patient to present for infusions on a fortnightly basis. Early data from the Chrysalis study showed that amivantamab had a response rate of around 40% for patients who are progressing on Olimertinib. But the move to the Mariposa study was based on this data in treatment-naive patients treated in Chrysalis 1 who received first-line amivantamab and Lazertinib. And you can see from the waterfall plot that the RECIST response rate was 100%. So everyone who received this therapy had at least a 30% reduction in their disease burden. However, the duration of follow-up was very short at only 7 months. And so you can see that the longest period of disease control in this study was out to 10 months. So we really don't know how much extra benefit we're going to get from adding this agent. The second study that is an all-comers study in this setting is the FLAURA2 study. So FLAURA2 is randomizing patients to either receive Olimertinib as a single agent or Olimertinib in combination with 4 cycles of platinum and pemetrexed followed by maintenance pemetrexed, with progression-free survival as the primary endpoint of the study. The design and the concept for this study is based on 2 previously presented studies. So on the left is the NEJ009 study, which was a Japanese study comparing gefitinib to gefitinib and platinum pemetrexed chemotherapy. And this study had a significant progression-free survival difference, but the statistical plan of the study was changed because they feared that they wouldn't reach overall survival significance due to other agents. And in the end, because of the changes in the statistical design, they couldn't claim superiority. However, you can see that patients who received gefitinib and carboplatin pemetrexed were living on average for almost 1.5 years longer, and longer than 4 years, which is what we was not reached in the FLAURA study as yet. A study that you as Indian specialists will be very familiar with, and I suspect some of you participated in, was the Tata Memorial study, which was of the same design and again showed a survival advantage for gefitinib, pemetrexed and carboplatin as compared to gefitinib. And on the basis of these studies and before Olimertinib became available in Australia, I have used this regimen with a few patients and found it very tolerable and quite effective. The other generic third-line studies that are running are firstly a United States study comparing osimertinib to osimertinib with bevacizumab. The recruitment is completed on this study and the results are pending. Prior studies with VEGF inhibitors or monoclonal antibodies have shown improvements in progression-free survival that have not translated to overall survival. So I'm not particularly hopeful that this study will show the overall survival difference that we're looking for. A study of lazertinib versus gefitinib is active but no longer recruiting, and it's double-blind first line. And I have a little bit of trouble that this study was run as the study commenced after the data for FLAURA were already known. And I think a better study design would have been to compare lazertinib to osimertinib as a non-inferiority study. And finally, the Chinese company making Olimertinib is running a study comparing this to Olimertinib in combination with chemotherapy, essentially the same study design as FLAURA2. We are very used to treating patients with first-generation inhibitors and on progression biopsying and looking for T790M. T790M occurs as the resistance mechanism to first and second generation inhibitors in somewhere between 30 to 50% of patients, dependent on the study. And it really has been the only pathway from first generation inhibition to another targeted therapy in our patient population. Osimertinib, on the other hand, and I suspect the other third generation inhibitors lead to a much more complicated pathway of, or multitude of pathways of resistance. So starting at the top of the pie chart, you can see point mutations or amplifications in EGFR, MET amplification as a bypass track, and to a lesser extent HER2 amplification is very common. Case reports of gene fusions including RET and BRAF and ALK have been reported. And there has been, again, some case studies of patients receiving a fusion-targeted TKI and showing benefit on progression on osimertinib. Point mutations, including KRAS and BRAF, have also been seen, and then cell cycle pathway abnormalities that might be amenable to CDK4/6 inhibition have also been seen. In terms of first-line phase 2 studies, to try and delay resistance to a third-generation inhibitor, we're seeing combination blockade between first and third-generation inhibitors. We're also seeing a very novel chemo or study design that commences patients on first-line osimertinib. So there is data that shows that patients with detectable circulating tumour DNA that does not clear adequately on commencement of osimertinib have a shorter progression-free survival. And so in this study, for the patients who fail to clear ctDNA after a defined period on osimertinib, they are then randomised to either remain on single-agent osimertinib or to add chemotherapy. And finally, there is a study looking at blocking the RAS-RAF-MEK-ERK pathway with the MEK inhibitor selumetinib in combination with osimertinib. And there's been some earlier data from the Tatton study on this approach showing a response rate, albeit in a small population, of 40% in patients with osimertinib resistance. Blocking MET is also being studied in phase 2, as are multi-targeted or VEGF TKIs and monoclonal antibodies, and also blockade of Aurora kinase. The second line studies that we've had also allow for generic mechanisms or multiple mechanisms of resistance. So there is a study called the COMPEL study that is very reminiscent of the IMPRESS trial that was reported by Tony Mock. So in IMPRESS, the question that was being asked was, on progression on the first generation inhibitor gefitinib, should you continue the TKI and add chemotherapy, or should you swap directly to chemotherapy and cease the TKI? And in the IMPRESS study, there was actually a harm was visited by continuing gefitinib beyond progression when switching to chemotherapy. potential reasons why Compel may have a better run is intracranial progression may be delayed by continuing osimertinib, but similar to Impress, I'm uncertain of the magnitude of benefit that might be realised by this approach. And I think looking for resistance mechanisms and rationally targeting them will probably be a more practical way to go. There are a number of generic second-line studies. So I've been involved in the HERTHENA study with a HER3 targeted antibody drug conjugate. And this study has now completed recruitment everywhere except for China. And a phase 3 study is in startup comparing patritumab deruxtecan to chemotherapy post-osimertinib. The Ocelot study follows an interesting concept of re-challenge, where patients are treated with osimertinib in the first line and receive platinum-based chemotherapy in the second line. And the rationale for this study is that by moving to chemotherapy, you may allow the EGFR mutant clone to recover and become resensitized to osimertinib challenge. The final 4 studies on the bottom of this slide show a variety of approaches, including CDK4/6 inhibition with abemaciclib, the use of PARP inhibition and immunotherapy for the small subgroup of EGFR mutant patients who undergo small cell transformation, or using a monoclonal antibody together with a HER2 antibody and continuing osimertinib, and finally a gene therapy in osimertinib. And I've listed the trial numbers there for those who want to go and look these studies up. Targeted second-line studies would have more appeal as far as I'm concerned, because you're trying to find a reason why osimertinib or your third-generation inhibitor is no longer working, and to target that pathway in oncogene-driven fashion. There are 3 phase 3 studies that are now recruiting that look at dealing with MET-amplified lung cancer on progression with osimertinib. All 3 studies have a similar design, where the control arm is platinum pemetrexed chemotherapy, and 2 of the studies are using osimertinib and savolitinib that I've misspelt there by accident, and the last study is using osimertinib and capmatinib. On the right is the response rate from the TATTON 1B study, and the second arm of the study where osimertinib was combined with savolitinib, showing a response rate of 40%, which for a second-line targeted therapy I would think is quite reasonable in this setting. So we wait to see whether or not these studies will provide us with another targeted option beyond osimertinib. 4th-generation inhibitors are now being developed, and the main thrust of these drugs has been to try and overcome C797S, which is seen as a resistance mechanism with 3rd-generation inhibitors. And indeed, there's also a C797S specific inhibitor being developed. And finally, there's another second-line targeted study in the MET space using tepotinib and osimertinib. The last few slides to do with studies is to present AstraZeneca's study, which is called the Orchard study. And I think the beauty of this study is that it takes all comers with progression on osimertinib, and it tries to find their resistance mechanism and then rationally assign them to a study arm. And this is a study design called an umbrella trial. And I think it's quite a nice idea, because you're not discarding a large number of the patients, and you're trying to find a bespoke therapeutic approach for each of them. So in this study, patients who progressed undergo next generation sequencing to try and look for one of the gene pathways listed as a resistance mechanism here that have been discussed before. In Group A, patients are assigned a biomarker matched treatment approach based on the resistance mechanism that is discovered, and each arm will enroll up to 30 patients to try and determine whether or not those therapeutic options are a good idea. There is a biomarker non-matched group who receive a number of more generic therapies, including chemoimmunotherapy or osimertinib together with an EGFR monoclonal antibody. And the Orchard study will be able to adapt and add new arms as it goes along. And finally, there is an observational cohort for patients who don't enter groups A or B. Liquid biopsy is a very user-friendly approach for caring for our patients and determining resistance mechanisms. And for those that are interested, there is a wonderful webinar from the IASLC that was presented earlier this year and is also available on YouTube for you to watch at your leisure. And this is an approach that I think many of us would love to bring to the clinic, but we're hampered by a lack of funding to be able to access the technology, even in Australia. Finally, I'll present a clinical case of a patient of mine managed with EGFR mutant lung cancer. So this was a 47-year-old Pakistani gentleman who was a never smoker, and he presented with palpable adenopathy in the right supraclavicular fossa and a biopsy-proven lung adenocarcinoma with an exon 19 deletion mutation. And you can see on this PET scan, he has a small primary tumour in his right lung with regional nodal metastases, both ipsilateral and contralateral, and also disease in the right supraclavicular fossa. And we completed his staging with an MRI of the brain that showed that at presentation he had about 4 to 5 small brain metastases, the largest of the 2 that I show you there. At this time, first and second generation inhibitors were available and reimbursed in Australia, but Olimertinib was only available on public insurance for patients in the second line setting. And so I had suggested to the patient that he join a study called the Outrun study that looked at the use of stereotactic radiation for patients with EGFR mutations and brain metastases at diagnosis. And this study is sponsored by TROG, which is our Cooperative Radiation Oncology Study Group, and co-sponsored by TOGA, which is the Thoracic Oncology Study Group, and it's called the Outrun study. And this study was based on papers that had suggested that patients who forego radiotherapy for control of their CNS metastases have worse outcomes. The major problem for my patient was that the Outrun study was not available in our home city of Perth, which is on the east coast of Australia. And this is the centre of my town. And so the only way that he could access the study was to fly to Melbourne, where he was randomised to receive stereotactic radiation and osimertinib. And he was due to fly back and forth monthly to be on the study, but not long after he commenced, the COVID pandemic hit. And all of the rest of his study involvement has been done by telehealth over the last 2 years. So at 12 months of follow-up, he had isolated what was called on his imaging isolated progression in the CNS. And you can see the 2 areas that have been treated with stereotactic radiotherapy showing central lesions with large areas of surrounding vasogenic edema. He was commenced on dexamethasone. He had a rapid response to treatment. And because of the amount of mass effect of the right frontal lesion, he was submitted to neurosurgery to remove this lesion. And we got the report back showing that he had radionecrosis, which is a late effect of high-dose radiotherapy to the brain. And we're seeing this more and more in Australia, particularly with our high rate of melanoma brain metastases, that patients are developing late complications of their treatment. And this is managed with surgical debulking when large, but otherwise steroids or bevacizumab. And so for our patient, so just by way of background, the average time to onset of this condition is around 1 to 3 years after high-dose cranial radiation. And there's a steep dose-response relationship, which is why we see it a lot more with stereotactic radiation. There's a very variable treatment course, and some of these resolve just with steroids, but with larger lesions, surgery is required. And in my patient, we were unable to wean him off steroids without developing symptoms. So he underwent, he declined to have the contralateral lesion removed. And so he had 4 months of bevacizumab. He had a complete response of his radionecrosis, and he's remained free of both lung cancer and radionecrosis in his brain. He now has oligoprogression in the lung at 2 years and is undergoing stereotactic radiotherapy such that he can remain on his osimertinib. So by way of finishing, Stanley Cohen was the discoverer of EGFR and subsequently the EGFR receptor, and he made these discoveries in the 1960s and won the Nobel Prize in 1986. The first papers of gefitinib and Olimertinib were released in the late 90s and early 2000s, but at that time mutations were not known about. We moved very quickly to understanding the importance of EGFR mutations in this patient population and how selecting patients can lead to remarkable outcomes. And then we've moved on to third generation TKIs. And for a while, Osimertinib was alone, but Osimertinib is alone no longer, and there is an increasing number of drugs coming to market. And really, we're all excited to see what the future holds for patients with EGFR mutant lung cancer as our treatments become less toxic and more effective, and our patients live with this not as a fatal disease, but hopefully as a chronic disease. So I'd like to thank the organising committee for inviting me to talk, and I look forward to joining in the discussions with the esteemed panel.
Thank you very much, Tim. That was a fantastic exposition. And I'm sure that all of us have learned a lot about how to fine-tune the management of our patients with EGFR mutated lung cancer. Now back to the organizers to continue.
Thank you so much, sir. Moving on to the panel discussion, I would like to invite our moderator, Dr. Amit Rauthan, medical oncologist from Bangalore, and our panelists are Dr. Kumar Prabhash, medical oncologist, Mumbai, Dr. T.P. Sahu, medical oncologist, Bhopal, Dr. Tim Clay, medical oncologist, Australia, Dr. Karthik Kudupa, medical oncologist, Manipal, and Dr. Bharat Vaswani, medical oncologist, Hyderabad. Over to you, sir.
Thank you very much. Good evening, everyone. I thank AstraZeneca for giving me this opportunity. And after hearing that wonderful talk about all the advances which are happening in the EGFR space, I think what we'll do is we quickly get down to what we do in clinics and how are we going to utilize all this information that we are getting. So let's just quickly go to testing strategies, because we keep hearing this. We've heard about tissue platforms. We've heard about blood-based NGS. We've heard about, in India, we still do a lot of hotspot testing. Quickly, Dr. Bharat, what form of testing do you do when you have diagnosis of lung cancer?
Normally, in all the cases, probably if feasible, we go ahead with a tissue-based technique. Now we are going we are going ahead with broad-based NGS techniques, sir. Probably, maybe there are some disadvantages in terms of turnaround time, but yes, sir. For all the patients, wherever it is possible, we go ahead with the tissue-based technique for further molecular subtyping.
And if tissue is negative, do you do blood NGS after that, or you stop?
Sir, so far, actually, we have not done it. The problem with us is the platform that we use. The cost is also a constraint in a country like India, and probably the best platform, Foundation, or when you talk as Guardian, Foundation Heme or Guardian, in terms of liquid, these are more costlier, sir. So probably, as far as now, at least I am not doing a liquid biopsy on day one. Only circumstances where you is probably when the tissue is not proper, the sufficient amount of tissue is not there, patient not willing for biopsy. There were one patient quite old enough. So probably in that case, I did it. But for all the things, as far as now, if the patient is fit and I am able to get a reasonable amount of tissue, I go ahead with my solid tissue biopsy.
Right. So I think that's what most of us do, tissue biopsy, tissue NGS, and then blood-based is added to it. But sometimes we reverse the sequence. Dr. Kumar, you had a very interesting paper this month in the Indian Journal of Cancer. Could you just tell us about your thoughts on this testing platforms?
I agree with the previous comment, and if you can do NGS, prefer it, especially on tissue. If you can't, then go ahead with the liquid biopsy. If it is positive, it is really good. You may find something extra. And if you can't, then the sequential testing also remains a good alternative. Catch those 4 of them where you have a drug easily available, where patient can take it. So those EGFR, ALK, ROS, BRAF, and PD-L1, if you can do it, that should be minimum.
Right. So we keep. I think all of us have devised various ways which we think are the best sequences for our patients and our situations where cost matters. So I think any of these is fine as long as we do test them. So looking at the when we find EGFR mutation positive patients and various stages, so just talking of early stage quickly, in maybe just Dr. Sahu, stage 1, 2, and 3 resectable adjuvant. Have you started using osimertinib for your patients?
No, right now, no. I don't have a patient on adjuvant osimertinib. I would love to, especially in the stage 2 and stage 3. That's the area where I would love to give. There are issues which was spoken by the previous speaker, but yes, the data looks very encouraging, and I think that should be discussed with the patient, no doubt about it.
Right. Dr. Tim, are you using it for your stage 2 or 3 patients, and what about that stage 1B?
No, not yet, but that is purely a matter of cost. And although I was saying that there were sort of controversies with the Adora study, I think at the moment, if I had a patient who could afford it, I would still start them on the therapy. The reason being, if there's not a survival advantage, we can always withdraw down the track. But if there does turn out to be a survival advantage and I've missed the opportunity to treat, I'd feel pretty bad about that. But we have the same issues of cost of therapy in Australia as you do in India in early stage.
Right. So all of us sort of agree on that stage 2, 3. The data is really very promising, and all of us would love to use it if cost was manageable. And this is something that we definitely agree is very promising. Stage 3 unresectable EGFR positive CTRT. Dr. Kumar Prabhash, what is your thoughts on this? Would you go the Pacific route, or would you want to give a osimertinib route for stage 3 unresectable patients?
Stage 3 unresectable 2 groups. If a patient has received chemoradiation, then at this moment, unlikely I'll prefer to give immunotherapy. I'll be giving TKI. Usually at this moment I don't do it. My concern remains, initially I have done it. Looks like when they fail, it becomes a challenge. For example, you're giving immunotherapy and 6 months down the line, patient is failing on durvalumab, and then there's a challenge. What do you do? Because there's a concern regarding those toxicity, and there is an issue regarding the real benefit of these patients. So I won't debate with a person, but I personally, when I talk to the patients, most of the patients, after learning, they say no, but some of them, they insist on taking, so I do give it.
Right, that's one of the most controversial spaces. I personally am not convinced enough to push my patients for EGFR positive patients, because you say stage 1, 2, and 3 resectable immuno doesn't work, stage 4 immuno doesn't work, and then suddenly there's this stage 3 in the middle where we say no, we should give them immuno for a year by Pacific. So it becomes very difficult. Dr. Tim, what do you do for your stage 3 Pacific, or you put them on osimertinib though the data is not there?
No, I mean, I've had, for example, outpatients with stage 3, and I haven't given them durvalumab. And I think there's this real problem with early stage, or with earlier stages of disease, that people are not yet thinking about stage 2 and 3 and 1 like we do about stage 4. And the biology is not different if it's early stage disease. If you're a smoker and you're high PD-L1, then that's the approach you should take. If you're EGFR, I have no doubt that we'll be treating on biology rather than on stage.
Right. So I think the stage 3 data set will be very interesting, and I don't see why it should be negative. The trial should be positive. The only thing is trying to give it indefinitely again in stage 3 is going to be very controversial. And I think as a design that kind of goes against our thought. For stage 3, you're going to put them on indefinite therapy with osimertinib. So that's something we'll have to wait and see. Right. So stage 4 patients.
I think in the stage 3, you will get a PFS advantage. It will be really interesting to look at the OS advantage. And if that really holds good, then it makes sense. And I don't know what would happen if they're giving indefinitely osimertinib. Can anyone tell them, the patients on the control arm, if they progress at any point, because there's indefinite osimertinib here, will they be receiving osimertinib or the standard of care at that point of time? That would make a difference in the OS. What is the control arm doing on the long run?
Yeah, so a point well taken. There is going to be
Dr. Tim or any one of you. My point is, it was a osimertinib indefinite. So the control arm is also to be looked at indefinitely, and if there is a relapse, so are we going to give osimertinib on the trial?
I mean, if you look at standard stage 3, the control arm of a lot of studies, the long-term survival is about 25%. So you would be over-treating a quarter of patients, but there's a large group that you'd be helping. But I think what we really need are biomarkers for relapse. And I very much hope that Laura is collecting serial biomarkers like ctDNA, because if you see a stage 3 patient and they've got no circulating ctDNA and they've got a very high survival rate, then we may be able to stratify and say, well, look, here's a patient who's got a very low chance of relapsing despite their presentation. They don't need it, or they're ctDNA positive and they do need it. We may find that might not work, but I think finding some biological marker that can point us to who really needs the therapy is one way we can spare toxicity for those who don't need it and spare cost.
Right. Moving forward for stage 4, I know we've discussed this multiple times in various platforms. It could be osimertinib alone or TKI chemo and TKI VEGF. Dr. Karthik, which side do you favor in your practice?
Yeah, I discussed osimertinib. I mean, I favor osimertinib, not chemo plus TKI.
Right. So osimertinib is the way for you. Okay. Dr. Bharat, your thoughts?
Again, sir, exon 19, exon 21. I'm more, if it is exon 19, I go ahead with my osimertinib. Maybe I'm not convinced with exon 21 because of OS. Data which shows that it is equal. So, sir, I give an option of chemo plus a TKI if it is exon 21. In exon 19, no two thoughts. I go ahead with my osimertinib.
Okay, right. Dr. Kumar, do you decide your thoughts on 1921?
Partly because that's the kind of information you have. You have 8 options, and explaining is a bit troublesome, but it is need to do it. So I usually divide those 3, first and second generation TKI. Then I put those other 5 in a separate group, and then explain my patient. And I do agree that a good number of patients wants to have tablet, but 95% of them can't afford it. And then you realize that gefitinib plus chemotherapy remains option for majority of the patient, because that also adds not only disease control and also add life to the patient. But I do agree that patients do prefer tablet if they can afford it.
Right. No, so we also are. It becomes a lot of discussion and a lot of debate for patients in first line setting. It's when you hear the people from the US talking, it's so much easier. They don't have much to debate about. They say osimertinib for everyone. Dr. Tim, is it the same for you? Osimertinib for everyone?
Once it became on public insurance, that has become the way we've gone. I see Dr. Sahu's posed the question in the chat about a study of osimertinib versus gefitinib and chemotherapy, and I suspect that study hasn't been done, but it's one that certainly a country like India, where you've got a large number of patients with EGFR mutations who can't afford to access osimertinib, it would be a very attractive study to run in your setting if your cooperative group was able to make it work.
Right. So Dr. Sahu should take it up.
I don't have the finances or the skill. I think Kumar is there, and I think this will be an answer to a lot of things. I think Dr. Kumar's group would have thought of that, and they would not be speaking out at this point, but I think this will answer a lot of questions. And if it is non-inferior even, and I think then the question of cost goes away totally.
See, the problem is, I think by then FLORA-2 will report, and if FLORA-2 comes positive, then again that study becomes a waste. So I agree,
but at least we know that osimertinib, we are giving something as good as osimertinib. That debate will definitely rest.
I don't think that study would be a waste though, because I think the thing is that there are large parts of the world where these drugs are not going to be as affordable as we would like them to be for a long time. And so having a patient who is having to pay from their own pocket, knowing that they can get equivalent outcomes for a lower cost, is still a valuable thing to know.
Right, but my thought is we already do that, in all our patients who can't afford osimertinib, we anyway do chemo, gefitinib, and Dr. Kumar's study, we kind of, we endorse it. It's really good and it's very effective in our patients. And there are majority of patients who can't take osimertinib.
One thing, can I come in here, Dr. Amit?
Yes, yes, sir.
My take on the things is that very clear, small things, that a first generation single agent TKI is no more an option.
Absolutely.
We have to add something to muscle to the first generation TKI. It could be chemotherapy. It could be a VEGF inhibitor. That's where the first generation TKI is. For the extremely unaffordable, who cannot even take a chemotherapy along with that, or a very frail old patient sick, that could be one of the patient whom all of us give Gefitinib single agent. Otherwise, I feel at this point the take home should be that the first generation TKI alone doesn't look good enough. You should add something to it. If the patient can afford Osimertinib, well and good. At this point, the data looks favorable for that. And I totally take that 21
Absolutely.
and 19 story. I
Absolutely.
would always discuss that.
So just one quick question on that before the last point when we move away from first line. Why was the phase 2 of Osimertinib Bev not showing even the PFS advantage compared to Osimertinib alone? That's kind of surprised me. Any thoughts on that, Kumar?
One of the reason given was Osimertinib working very well in the brain, and Gefitinib, and Erlotinib especially doesn't work so well in brain, which gets compensated by VEGF inhibitor. And but that's a partly, I think so, the answer. I think so. That is what teaches us that when you combine things, it's not always 2 + 2 in medicine. Right. And I tell you, when we added this chemotherapy plus TKI, we didn't know this result. We kept thinking. In fact, we had put our first study, which we stopped doing it because of cost. That was Gefitinib plus Bevacizumab. That was our first study, which we were about to put in the IRB. But because of cost, we couldn't do it. And then we put this study, and then we kept debating in between. Should we stop in between? Did we give platinum? Was it unnecessary? Could have given only platinum. But that's where the science is.
And turned out a very good gamble, because the other side may not have worked. So it's really.
I agree with you. At the end, it looks good, but yes, it can be an interesting discussion some other day.
Right. So we're moving forward. When we talk of more progression on Osimertinib, we heard this in the talk. We talk about secondary mutations. We talk about bypass signaling. We talk about biopsy for transformation. So testing post Osimertinib. Now, I think we'll just take this testing directly with the case so that we don't repeat things. So here's a case. The first patient, a 44-year-old non-smoker who presents with dry cough. So these are actual patients which have been published, and this is taken up from that data sets by AstraZeneca. So this patient had a right lung mass and metastasis to hilar lymph nodes and brain mets and a EGFR 19 deletion. Patient was started on Osimertinib 80 mg, received partial response, and had a PFS of 16.8 months, after which he progressed with multiple liver lesions. So Dr. Karthik, how do you take up this kind of a patient who progresses? So first thought is on testing. How do you test these patients when they are progressed on Osimertinib?
Yeah, I mean, I know that there are a lot of data regarding liquid biopsies, but still I'm going for tissue biopsy. So if this is a liver metastasis, probably easily accessible. So I would like to do a biopsy of the liver and send for NGS.
Right. So biopsy and NGS, and so this patient had a biopsy just like you suggested, and they got a EGFR C797S mutation. Dr. Bharat, what are your thoughts on this kind of management?
Actually, probably I'll be putting him on a first generation TKI, because we know that C797S with the data available responds very well to first generation. So probably a Gefitinib probably will be a valid option here to start with, because we have.
Right. So that's how the data goes. They do talk about a cis and a trans mutation, and they say if there is a transmutation, you can actually add in a first generation TKI to Osimertinib. Again, I don't know if there's any real world experience with any of you having a C797S and treating it this way. I don't have any personal experience in this. Dr. Tim, do you have any experience with this?
No, we have the same problem that NGS is not readily affordable in Australia yet. So the number of patients who I have who undergo it's not particularly high. But I'm very aware of this data, that the one patient that I've tested had a KRAS mutation. The other one had a small cell transformation.
Right. So I think testing is becoming important, and this is the data about it, and this is the Orchard study which you showed. Right. So this patient was treated with the first generation TKI. Olimertinib was added to Osimertinib and got a PR, and they did a liquid biopsy and they saw that the EGFR C797S was undetectable on the liquid biopsy, and the primary mutation was still there. And there was progression disease after a PFS of about 3 months. So this is looking at on-target mutation. Now, this is a second case we'll run through very quickly. This is a 69-year-old never smoker diagnosed with adenocarcinoma, EGFR deletion 19. He had multiple bone mets, lung mets, and asymptomatic brain mets. He got afatinib and he progressed in his disease after 15 months. Progression at the primary site, and again, new onset liver metastasis. So again, we have discussed the biopsy steps. So this patient underwent a biopsy and got a T790M mutation. Now that is straightforward, and we treat them with osimertinib, and then he progressed after 8 months. So this is a case from Dr. Ullas Batra. So what would you do at this progression? So he's got erlotinib, progressed, and then got a T790M, got osimertinib, and then progressed. Dr. Sahu, what do you do in this group of patients?
I would again love to do a biopsy and look at the mutations. I think that does give an idea. There are reports of the HER2 new and the MET and the KRAS and the BRAF also. So if there is something, then you would get a target to go through. If not, then chemotherapy definitely becomes a standard of care.
Right. Do we really get to do 3 times NGS testing in our patients? It becomes so difficult in clinical practice. Dr. Bharat, do you have that opportunity?
Actually, a similar patient of mine, probably I thought my patient only, sir, might be, because we had included in a clinical trial. Sir, we do fish for all the patient who progresses on osimertinib, we do fish for MET amplification. Because we have 2 patients now, which we have got MET amplification, and we have one is on savolitinib trial, and when we gave capmatinib along with osimertinib, did well for 7 months, sir, and then again it progressed. So if I can't do an NGS, I make sure that I do a fish for MET amplification, because I had 2 patients in the last 6 months now.
Right. So MET amplification becomes one of the dominant pathways for resistance to osimertinib, and that's something that all of us look for in various ways. So doing NGS makes sense than trying to pick up whatever you come out. Now, this was what Dr. Ullas had done. He started chemotherapy with pemetrexed, carboplatin. A repeat biopsy of the supraclavicular lymph node was done. Again, the patient had further progression, and then they found there was ALK fusion positive along with the EGFR. So this is a patient who now has an ALK with an EGFR. So you're talking of a dual pathway there. And so the thought is, would you use an ALK inhibitor if you find one like this? Would you be comfortable using one, Dr. Karthik?
Yeah, I think so. I think because the patient is progressing on chemotherapy, on EGFR inhibitor, so, and he has got an ALK mutation. So probably I will discuss the option of ALK inhibitor here.
Right. So I think that's what. So this is what he did, and he started patient on alectinib with osimertinib, and this is the pictures shown of dramatic responses. So this is how an inhibition of the dual pathway can work. So it is worth looking for, worth searching for, and this is. I'm sure Ullas must have presented this patient in multiple platforms. Now, there is some French database with very limited numbers showing that EGFR versus EGFR plus any mutation, again, additional mutation leads to poor survival, poor prognosis. And of course, we know when progression, if we find a MET or something, we can always add in a second therapy. So moving on, the third and the last case, very quickly. This is a 45-year-old female non-smoker, develops stage 4 with EGFR exon 19 deletion, treated with a first generation TKI, does very well for 9 months, then progresses with 2 new bone lesions. What do you do in this situation? Dr. Kumar, 2 questions come in, just radiation continue or doing testing with looking for T790M, do you do that in oligoprogression or not? Okay, I think Dr. Kumar I've lost. Dr. Tim, in practice, when you have oligoprogression, which are your thoughts?
If I couldn't find T790M, or if it was too hard to biopsy, I would go with stereotactic radiation. and try and preserve the systemic therapy rather than changing, given that she's otherwise doing very well.
Right. Okay. So, but if you so that's the conflict which happens. We prefer just giving stereotactic radiation and continue treatment, but because NGS becomes so easy, sometimes we just send a blood-based testing. Not even an NGS. We're just sending a blood-based looking for only the EGFR by digital droplet, and we find a T790M. So then there's a conflict there in our thoughts. Dr. Bharat, if you found the T790M and you had taken a decision for doing just the SRT and continuing first generation, would you change or would you just continue it?
I'll change, sir. If it is T790M, I know there is a resistant pathway that has come up. Osimertinib has a documented good clinical efficacy. I'll change it, sir. I'll not wait for it. If I get a T790M, I'll change it to Osimertinib without waiting, and then give a local therapy also.
Okay. Dr. Sahu, you'd be tempted to continue and get the maximum out of the first line?
No, I would not. I'll probably do the NGS. If I have a target, I'll change it. If not, and the patient is mildly or asymptomatic, I might take that extra 2-3 months giving RT, but discuss and take a good consent. Because that's what really the patient, if deteriorates fast, sometimes you've seen you will never get a second chance. If there is a mutation, I will definitely go ahead and change it.
Right. So T790 is something when we see all of us want to change immediately to osimertinib, and that's one place where we change immediately. But if we don't see one, then definitely giving radiation and continuing treatment. So this is oligoprogression, and we have given radiation and treated. Now this patient was managed with radiation and then osimertinib for 6 more months and then progressed and further.
Can I ask one more question? If this would have been a brain mets, no other extracranial, and then someone out of curiosity did NGS, then do you change it, or does it remain the same, or in brain met single progression we don't do NGS? Can that be clarified?
So I think one point to make with the drugs is that osimertinib was designed was designed to be CNS penetrant, and so I've had patients who've had isolated intracranial progression where I've changed them to osimertinib without an NGS and got a response because you get higher penetration. And in the days before osimertinib, I was either adding bevacizumab or I was giving pulsed dose EGFR TKIs. So very, very high doses once a week.
Right. Right. Okay. So this patient has again a liquid biopsy which shows no EGFR mutations. So now what is your choice of third line therapy? So this patient was offered the combination of chemo, bevacizumab, immuno. What is your experience with this? Dr. Karthik, have you tried it in your EGFR mutation positive patients using this triple combination chemo, immuno, bev?
Yeah, I mean, I've not tried it, but the data looks good actually. So maybe I think I would have done the same thing. I've basically discussed this option with few of the patients, but they didn't go for this.
Right. Okay. Dr. Bharat, have you used this combination for EGFR positive?
Probably cost again is a concern. By this time, most of us have exhausted our coffers, sir. A single patient, not much of a data, but yes, sir, exciting. Probably a small data, but probably the best we can have at this moment, sir, in the third post progression on these things, but not much of an experience because of cost constraints.
We have some limited experience, but again, Dr. Tim, what do you do? Where do you use this setting? Do you use it?
So I think there's been a habit because of alopecia from paclitaxel to substitute pemetrexed for paclitaxel, and there is some data for that combination. I have had a patient who I put on this regimen and they didn't stop taking their osimertinib as instructed, and they got a fatal encephalitis. So I've had one extremely bad experience, but I've had a number of patients who've done well on the combination as well and got an extended period of benefit. And I think the thing about the study that this is based off is it was the only one that's read out that allowed this patient population in. So the reason it's become taken up is because it did include patients with these mutations.
Right. So we used to do a lot of chemo, bevacizumab at progression. It's just that they're adding that immuno always is the issue of cost, and that becomes an issue. What are your thoughts on using chemo, bevacizumab, and just continuing osimertinib? Do you continue osimertinib at progression if there has been, the brain has been well controlled? There's a lot of talk about that.
Our insurance schemes don't allow us to do it. So generally I haven't, but you know, VEGF inhibition, as we've talked about, is quite active in patients with EGFR mutations. So the main reasons I wouldn't use bevacizumab is if they've got cavitating lung lesions or a history of significant thrombosis, so contraindications, but otherwise I would be wanting to include it with chemotherapy.
Right. Okay.
Sir,
So
I have a question, sir.
yes.
Sir, probably periphery controlled brain progression on osimertinib. So, sir, the thought of doubling the dose as per as Bloom's data, or should you change it, sir? Progression only in brain, peripheral control on osimertinib patient. What should we do, sir?
Right. Very interesting question. So we have used the Bloom data in leptomeningeal metastasis in some group of patients at progression, doubling to 160 and we have a reasonable control for long term. Yes. But again, in this setting, Dr. Tim, what would you do?
I haven't had any experience because of cost, patients can't afford to double the dose because they access osimertinib through public insurance, so they can't do it. So we would generally be adding in whole brain or targeted radiotherapy. There are a number of interesting series of using intrathecal pemetrexed out of Japanese groups. So if you've got a patient who is able to have and again, I haven't done this, but able to have a reservoir and have intrathecal pemetrexed, it appears to be very active in this population.
Oh, that's very interesting. We've never heard of intrathecal pemetrexed. Oh, that's something we'll look up, because leptomeningeal disease becomes a major issue in our patients. We've had a couple of patients who have got the Bloom data type of osimertinib dose and done reasonably well for some time with clear responses. They progressed on ATMG, CSF becoming negative, leptomeningeal enhancement coming down. So this is something possible, but yes, it becomes an exorbitant cost for patients. So I think with this, we are coming to the end, and this is the IMpower 150 data. We have seen this already and discussed about it. So this is the last slide to summarize. When patients are treated with osimertinib, we need to look at why they are becoming resistant. We need to look at alternate pathways. So it could be on target, it could be off target by bypass mechanisms, it could be a small cell transformation. And then there's those wonderful new trials running. There's a lot of things happening in the EGFR space, as Dr. Tim has already showed us. So with this, I would like to thank all of the panelists for that excellent discussion, and thank you very much to AstraZeneca. Over to you, Dr. Sana.
Thank you so much, Dr. Amit, for the wonderful panel discussion, and all the panelists for the active participation and discussion. Dr. Tim, thank you so much for your talk. Are there any questions, follow-up questions? So there was one question, Dr. Amit, when we were discussing about using erlotinib versus ramucirumab in as an option to treat these patients.
Right. So the relay data. Dr. Tim, I'll take your thoughts on the relay data sets.
I think the relay data set was in the first line from memory. And so as we talked about, I think that there's been some progression-free survival advantage, but not a major overall survival advantage as far as I'm aware. And I think there'll be other strategies that'll be preferable. I mean, the amivantamab lazertinib data, 100% response rate, although it's small data, is very impressive. So I think that the VEGF first-line strategy will fade away as more exciting things come through.
Right, and even the second line, the late line patritumab data is amazing, and that's so biomarker independent. It's and HER3 HER3 antibody drug conjugate. So there's amazing things happening in this space, and I think it'll be a very exciting time ahead for our patients.
Okay, so that was the only question. So thank you so much, everyone, for joining in. Thank you.
Thank you.
Thank you for having me again.
Thank you.